Good evening, everyone. Yay, we're going to start. Yay. Sorry about the delay, 15 minutes. We apologize for that. My name is Lisa Morris. I'm the Director of the Division of Public Health Services at the Department of Health and Human Services, and we welcome you here tonight. I was surprised to hear that it's been quite a while since we've been here, so we're very pleased that we were invited to come and that we're able to be here with you today. So we have some wonderful speakers, and then we'll have some time to chat with you. And at this point, I'm going to turn it over to Lynn, and Lynn will recognize the speakers. Thank you.
Good evening, folks. Welcome to the high school. We've got 3 speakers tonight. We're going to start off with Dr. Chan doing an overview of the PFAS. Then we're going to Jonathan Olli, who's a toxicologist, going to be talking about the drinking water standards. And then we'll go to Captain Tara Summers, who will be talking about the health study. After that, our speakers will come up here and they will hold about a half an hour question and answer session. And I would ask if you could keep your questions concise. We're not expecting reviews or any other things. We're strictly expecting to have questions tonight. When we're done with that, the speakers will all be available in the room for one-on-ones for anything that else you'd like to discuss, either private or that didn't get attached tonight. So let's start off with Dr. Chan.
All right, good evening. Glad you all could make it here on this gloomy evening with some precipitation out there. So my name's Ben Chan. I'm the state epidemiologist with the Department of Health and Human Services. Can everybody hear me okay? All right. I'm seeing some head shakes, so I'm gonna have to lean over here. Okay. So I apologize if my voice gets a little hoarse here, or if I start coughing. I'm getting over a little bit of a cold. So again, I'm with the Department of Health and Human Services, and I think we've realized we haven't been back down to Merrimack in a while. And I know that our colleagues in the Department of Environmental Services, Clark Frizey, Dr. Olli, who you're going to hear from in a minute, have been frequently here, and so we tend to work in coordination with one another. But I think this is an opportunity for us to give you a brief overview, again, of some of the what's known about the PFAS chemicals, especially for those who may be new to this issue, and to talk about some of the work and some of the resources that are out there before I hand things over to Dr. Olli. So I'm going to start I'm from the Department of Health and Human Services. Dr. Olli is going to pick up talking from the Department of Environmental Services. Then Captain Tara Summers is going to give a brief overview of some of the national work going on around PFAS chemicals, and then we're going to end with a question and answer time. So just to step way back, going back to the beginning of when we in New Hampshire started dealing with these chemicals, we initially referred to these chemicals as PFCs, perfluorochemicals. And the terms have changed over the course of the investigation, not only in New Hampshire, but nationally. And so this is a family tree, if you will, of the different chemicals related to PFAS, what we now call PFAS. Per and polyfluoroalkyl substances is what that term stands for. You can see that the term PFC has now fallen off the tree. And so I may slip back into the old terminology once in a while, but just know that the term PFC, or perfluorochemical, is synonymous, is the same term as what we now refer to as PFAS, perfluoroalkyl substances, okay? Again, PFAS chemicals, these are a diverse group of man-made chemicals that have been used widely, not only in industry, but also in home products since about the 1950s. I've heard differing accounts. There's at least 3,000 chemicals in this family, if not more. I've recently heard maybe more than 5,000 chemicals. So this is a very diverse group of man-made chemicals that are out there. And they're used extensively because of their chemical properties. They resist water, they resist stains, they resist oils, and for that reason, they're used widely in many commercial and home applications. The problem with these chemicals are that some of them persist for years, if not decades, in the environment. and they can accumulate in people's bodies. The half-life, that's the time it takes for a body burden to go down by half, can be on the orders of several years with some of these chemicals. Now, you'll hear these chemicals referred to by different names or acronyms: PFOA, PFOS, PFHXS, and PFNA. These are abbreviations that we use because the names of these chemicals tend to be very long, like perfluorooctanoic acid, it's PFOA, perfluorosulfonic acid, PFOS. These are 4 specific, so remember, 4 out of more than 3,000 or 5,000 types of class of these chemicals that are most commonly, or have been most commonly found in home environments that people have been exposed to. And so you're going to hear more about these chemicals coming up. This is a list. It's certainly not an all-inclusive list for the type of products that these chemicals have been used in. Right, anything from stain-resistant sprays. They've been used in carpets, so stain-resistant carpets, stain-resistant furniture. They're used in apparels like Gore-Tex, for example, and other water-resistant apparel uses these products. They can be found even in some personal care products like dental floss. And then historically, these chemicals have been used in food packaging. So because of their stain and grease-resistant properties, they've been used in the past in pizza boxes, popcorn bags, packaging that resists stains and grease. And that's just in the commercial products that might be in our homes. They're also used extensively in various industrial processes. The primary way that people are exposed to these chemicals is by orally ingesting them, so consuming them by mouth. This can be through contaminated food or water. We're here this evening because of concerns around exposure through contaminated water. And again, historically, food packaging that have used these chemicals have led to exposure because the chemicals in the food packaging can migrate into the food. People eat the food, and then they're exposed to these chemicals. Ingestion of contaminated dust is also a large source of exposure. So if someone has stain-resistant carpets or upholstery or furniture at home, the dust in the home can pick up these chemicals, and then people can be exposed to these chemicals through the dust. This is also pertinent for young children, infants and toddlers that may be at home crawling around, putting their hands in their mouth, putting toys in their mouth. There's been a lot of concern expressed about, well, if these chemicals are in the water, what if I'm showering, what if I'm washing my hands in this water? These chemicals are not thought to present a significant exposure through the skin, right? They're not readily absorbed through the skin. The main way that people are going to be exposed to them is through ingesting them by mouth. There has been concern also because PFAS can be passed through to babies during pregnancy, so through the placenta, and also through breastfeeding, through breast milk. Different types of chemicals are passed in different amounts through the placenta and through breast milk. But I think it's important to remember that the recommendation, and there's been some concern around this, but the recommendation is still that nursing mothers continue to breastfeed because of the many known benefits of breastfeeding. The American Academy of Pediatrics put out this statement stating that even though a number of environmental pollutants readily pass to the infant through human milk, the advantages of breastfeeding continue to greatly outweigh the potential risks in nearly every circumstance. And I just want to make mention of that because I think Dr. Olli is going to be talking a little bit more about how some of the recent water levels were established in New Hampshire and looking at exposures to infants and newborn babies. Technical difficulty again. Is it frozen?
There you go. I got it.
Okay, this seems to be working
Okay.
now. All right, so As most people in the United States have been exposed to these chemicals. So if you go out and test the general population, more than 98, 99% of the population, the general public, can have these chemicals found in their blood, in their bodies, because of how widely spread these chemicals have been used. Some of the primary ones that have been tested for, PFOA and PFAS, have been phased out of production in the United States. That took effect sometime in the last 5 years or so, and they're not currently being used extensively in the United States. However, they may still be used in other countries or in products imported from other countries. But because of this, the exposure levels in the general US population have generally been decreasing. So this graph on the right is actually from the CDC or ATSDR's website, which is showing the levels of these 4 most common PFAS compounds: PFAS, PFOA, PFHXS, and PFNA. You can see that over time, so moving from the year 2000 to 2014, the average blood PFAS concentration in the general U.S. population has been decreasing. Now, it's important to note that if there's someone that has an identified exposure, such as through contaminated drinking water, likely the person's body burden, their blood level of PFAS is going to be higher than what we say that the general U.S. population. What we found, though, when we've done different exposure assessments in different communities, is that people that are consuming contaminated drinking water at the levels we've seen around New Hampshire, they may be higher than the most recent U.S. population data. A lot of times, average blood levels are more similar to what's been found in the general U.S. population, 10 or 15 years ago. And I'm going to show you a graph a little bit later which shows that. So obviously, anytime there's exposure to chemicals, there's concern for health. The science on this is around PFAS impacts on health is still evolving. There's a lot of research coming out around the potential health impacts of these chemicals on people's bodies. You may have heard these chemicals referred to as endocrine disruptors or having impacts on the endocrine system. And there are a number of health outcomes that are being looked at as potential health complications from exposure to these chemicals. That includes changes in thyroid hormones and sex hormone levels like estrogen. There's been study looking into whether these chemicals may impact or affect the liver and looking at liver enzyme levels, cholesterol levels. There's concern that these chemicals may impact someone's immune function. For example, looking at antibody response to immunization or vaccinations. There has been some evidence showing some potential impact on growth and development, especially relative to there being an impact on lower birth weights in infants born to mothers that have been exposed. And then the occurrence of some types of cancer. Some studies have found an association, such as with prostate, kidney, and testicular cancer. I will say that some studies have found associations or connections, and some studies haven't. So a lot of the science on this is still a little bit mixed. And the long-term health complications from this are still unclear and being studied. So it's difficult to say what exactly someone's risk is if they've been exposed to these chemicals. I just want to walk you for a few minutes through some of the work that we've done here locally, and then work that's being done nationally before I hand things over to Dr. Olli. Most of this, if you've been tuning into the situation, should not be new information. But I first want to point you to several sites that you can look at for additional resources. So the New Hampshire Department of Health and Human Services has our website. And actually what I didn't put up here was the Department of Environmental Services website in New Hampshire. I should have included that on here. We have different sets of information. I will show you some data that we have available on a data website that we have called the Wisdom website. And then one of the sources I always point people to is the Centers for Disease Control and Prevention's Agency for Toxic Substances and Disease Registry, ATSDR. Their website has a wealth of really valuable information, and Captain Tara Summers is from the ATSDR, and she's going to be speaking a little bit later about some of the national work. And I'm sorry this hasn't come through very well, but we have done exposure assessments in multiple communities around New Hampshire, both out at the Pease Trade Port beginning in 2015, and then moving into the southern New Hampshire communities, those on private wells, but those also on the public water system, the Merrimack Village District, or MVD public water system. And so in each of those locations, we've done an exposure assessment and have performed testing of people's blood to get a general sense of levels of exposure in those communities through contaminated drinking water. We have made that data all publicly available online. I'm not going to go into great detail, but that's online that you can find through this website here in the middle, and we can post these websites online afterwards. But we have graphs of different exposure levels, and we break this up by gender and age. And I apologize that this is not coming through very well on this screen. We have also taken our data and we have tried to summarize it. Actually, I'm sorry, before I get to that, one of the communities we performed an exposure assessment on was, again, the Merrimack Village District public water system, what we call the MVD Community Exposure Assessment, where we did a random sampling of over 200 residents on the MVD public water system that was inclusive of more than 130 households. The purpose of this exposure assessment was to give some generalizable information to the population as a whole around typical levels that could be seen, exposure levels that could be seen from consuming the drinking water that had levels of PFAS in them. And I'll mention that residents had higher levels of PFOA exposure compared to the general U.S. population, which was not unexpected given that the general U.S. population includes people with no clear identified exposure and those potentially with some exposure. But as a whole, if people are consuming contaminated drinking water, the blood levels of these PFAS are expected to be higher than the general U.S. population. So we've taken this data and we've put out comparisons. This is something we've presented at one of these community meetings before. Again, you can find this online, where we compare the blood testing that we've done in different communities, both at Pease in 2015 and Pease in 2016 and 17 with Southern New Hampshire private wells, with the MVD public water system, with the general U.S. population. And so you can see, you can look by community the different levels of exposure that have occurred. It's important to note that when we've gone out and we've done the blood testing, the blood testing is difficult to interpret in terms of how it relates to someone's health. There are not cutoffs to these blood levels that are considered normal versus abnormal, or a level at which someone is identified to be at an increased risk. So one of the ways that we help people interpret what the blood levels mean is simply by comparing them to other populations that have been tested. And we've tried to do that to the best of our ability, looking not only at the New Hampshire populations here and here, but comparing it to the general U.S. populations tested at different times, and then other other populations that have been exposed throughout the last number of years of testing. You can see that some of the occupational exposures that have been tested, the occupational workers that have been tested have been very, very high, and some of the exposures more locally are around closer to what the general U.S. population exposure was back 12, 13, 14 years ago. Again, a lot of this information can be found online. There's been concern around PFAS exposure and cancer. In January of 2018, so a little over a year ago, coming up on almost 2 years ago now, we released a cancer incident report specific to the town of Merrimack using our cancer registry and our cancer data. I point you to this also because it also provides a summary of some of the science around PFAS exposure and what's known about PFAS exposure and cancer. This report did not identify any statistically elevated rates of cancer in the town as a whole, but again, this is a very crude measure of potential health impact from PFAS. There's also been concern around how someone's health should be monitored. who's been exposed to these PFAS chemicals. We've done quite a bit of messaging to healthcare providers. This is a difficult audience to engage. This is an example of one of our health alert network messages that we routinely, or periodically I should say, send out to healthcare providers to provide them with pertinent and important information. I think this was the 7th communication that we've put out to healthcare providers on the PFAS issue over the last several years. This most recent communication done this summer was in response to the new MCL levels, the drinking water levels that DES released, and we try to connect our healthcare providers with resources, including some clinician guidance that's been put out by ATSDR. This is the healthcare provider guidance that's been put out nationally by the Centers for Disease Control and Prevention's ATSDR. The purpose of some of this guidance is to help clinicians address health concerns that individuals may have relative to PFAS exposure, and helps give some guidance and directions about how healthcare providers can monitor the health of individuals that have been exposed. I will mention this as an ongoing challenge. Healthcare providers are a difficult group to engage, and so we've heard over and over in our engagement with communities that people have gone to their healthcare providers expressing concerns around exposure to these chemicals, and a lot of the response has been, well, we don't know what these chemicals are. And for that reason, we have done multiple attempts at outreach and continue to work on improving our communication with clinicians. Now, New Hampshire is not the only state that is identified as having PFAS contamination. This is a national problem. Not only is it a national problem, it's an international problem. This is a map simply looking at sites around the country that the CDC, specifically ATSDR, is involved in. You can see two, and again, the state boundaries here don't show up very well, but there's 2 spots in New Hampshire. So the seacoast around Pease Trade Port, and then in southern New Hampshire, there's some spots in New York and Pennsylvania, Massachusetts. But this is an issue that really has gotten a lot of national attention. The ATSDR is out there working with other states to also perform exposure assessments, similar to some of the exposure assessments that we've done here in New Hampshire. The same type of work is being conducted nationally at these spots of contamination around the country. But it's not just about exposure. We need to learn how exposure relates to health outcomes. And so there has been congressional funding put through to fund a national, what's being called a multi-site health study to look at the potential and further the science around the potential health impacts from PFAS exposure. The study is going to involve at least 6,000 adults and 2,000 children. It's actually, the multi-site study is 7 different sites nationally, but then we have the Pease Trade Port in New Hampshire that serves as the pilot for this larger multi-site national health study. And you can see that the sites that are being included in this multi-site national study really involve states all across the country, from New Hampshire to California. Now, I will mention that there was an effort to include the southern New Hampshire, so the Merrimack, Litchfield, and communities surrounding the St. Gobain performance plastics plant. There was efforts to involve these southern New Hampshire communities in this national health study. In fact, there was an application for funding put out from some academic researchers, along with Lorraine Allen, who's in the audience here. We wrote a letter of support, and as DES did as well, hoping to have our southern New Hampshire communities included in this study, and I'm sorry to say that that application was not accepted. However, the findings from this multi-site national health study are expected to be applicable to all communities that have potential exposure to these chemicals through drinking water. I want to acknowledge that there are many challenges, and I think that the communities that we've engaged have been working through these challenges with us. As we've learned more about the level and the extent of contamination and the potential health impacts, right? It's not just New Hampshire. There's communities all across the country where these same scenarios are playing out, and so the extent of the contamination, the exposure is very large. Many of these communities have had exposure assessments done, so blood testing. It's challenging to interpret what these blood tests mean, and so that's been a challenge not only for communities in New Hampshire, but also nationally. We also don't understand the health risks, the human health risks very well, and so that's something we're still learning about. That's why studies like ATSDR's National Multisite Health Study are important, but the health information and the science around PFAS and their impacts on health are rapidly changing. There's new PFAS compounds that are being created and used, right? So I mentioned that PFOA and PFOS, those two specific PFAS compounds, have been phased out of production in the United States. But remember, this is a class of more than 3,000 different compounds, and so there's new compounds that are being developed to take their place. These new PFAS compounds have much less science associated with them. There's been much less study of them, and so we don't know what the health impacts are and whether it's a class effect versus an individual chemical effect, and so we're still evaluating different PFAS compounds and different mixtures. And then there's challenges with implementing and cleaning up water systems that have been identified to be contaminated. The extent of contamination is large, and the treatment and cleanup costs also are large and can take some time. And that's something that our colleagues in the Department of Environmental Services have been very extensively involved with, not only in this community but others. So with that, let me end. I'm going to turn things over to Dr. Olli, and he's going to talk a little more about New Hampshire's new drinking water standards for PFAS.
Can everyone hear me? Yes, okay. So before I get started, there are actually some familiar faces in the room. Could I just get a show of hands of everyone from Merrimack? Okay. Londonderry. Nashua? Bedford. Any communities I have not named yet? Litchfield. Thank you. Okay, and one last poll. Can I get a show of hands for anyone who this is their first time coming to a public meeting about PFAS? Okay, so we have a couple of new people. Track me down after this, because I'd like to get to know everyone. So I'm here to talk about the drinking water standards that were set by the Department of Environmental Services. So, make sure I get this right. It's working. So I'm going to talk about what is the drinking water standard. Sorry, I'm arching over intensely. Then we're going to talk about why NHDES recommended this limit, and then we'll talk about what you can do and then what our next steps are. So to start out, what the limits are drinking water limits. These are enforceable standards that need to be met by your public water supplies if they're going to be providing you with safe drinking water. And this is in response to House Bill 1101 and Senate Bill 309 that instructed DES to set drinking water standards for 4 of these compounds, so PFOA, PFOS, PFHXS, and PFNA. But it also gave us the authority to definitely regulate air to groundwater contamination, which has been the major issue down here in Merrimack. But it's also instructed us to develop a plan of how we protect surface water, because your environmental resources are more than just your drinking water. There's also the surface water, the fish that we eat, and all the other resources. So the idea was setting these maximum contaminant levels would be a process that was taken out over last year. So we proposed a draft set of numbers in January of 2019, and then we adopted final numbers in July of 2019, and then at the end of this past September, we made the numbers official and have adopted those. So now what you're seeing is a lot of drinking water systems have begun testing to see where these contaminants are. A lot of people are getting notifications about this because we're starting to understand how far spread this is. So what are the numbers? So for each of these chemicals, they have a specific number that is estimated by our department to be without risk across your lifetime of exposure. So that's 12 nanograms per liter or parts per trillion for PFOA, 15 for PFOS, 18 for PFHXS, and 11 for PFNA. So these are the numbers that we compare test results to determine if they are above or below our limit. So the question is, why did we recommend these numbers? It's not a roulette game. So what we did was risk assessment. And what risk assessment involves is a process of hazard identification. This is where we go through and we look at what are the effects of PFAS exposure, is there strong evidence in human and/or animal studies, and also what's our current limitations of our knowledge. So as a toxicologist and working with the risk assessors at DES, we look at human epidemiology data, animal toxicity studies, and in vitro or kind of like petri dish studies where they put cells in petri dish and then dose them with chemicals. And we try to combine this information and understand at a population level what are the risks from exposure. Now this is different than clinical guidance. So again, this kind of risk assessment is not comparable to what a physician would use to set a diagnosis level for a patient of you have an individual increase in X. This is not a clinical value, this is a population risk assessment value that's standardized, and this is how risk assessment is done for all drinking water standards. Sorry. I'm trying to see if I can. Okay. So the idea is we do hazard assessment to identify if these are a problem, and then we do risk assessment to actually quantify this, and then translate this into a drinking water number. And over the last year, we've done several public meetings where we've talked about this process and the calculations that were used. I'm not going to go into depth about that tonight, but that's something that if you have questions, I'm more than happy to answer them. So when we do hazard identification, one of the first places we start with is trying to look at where are some of the federal agencies at. And part of this work was looking at where the Agency for Toxic Substances and Disease Registry, we always use the acronym ATSDR, but I thought it'd be helpful to spell that out. So we kind of look at what do we see in the animal studies and then what do we see in the human studies, and based on that, where we sort of see agreement, that's where we start to identify, okay, these are the health concerns that we need to focus on. So this is an ongoing area of research, as mentioned by Dr. Chan. A lot of this is evolving right now in our understanding. So we're starting to see that these chemicals will probably affect several biological processes in the human body, not just the immune system, not just the liver, not just development. But as a part of this process, we try to select the most sensitive of those that's relevant to human health, and we use that as the basis of protecting your drinking water. Now, what's unique about PFAS is that, sorry, I know this is a kind of small diagram up here, but what's unique to PFAS is that, unlike other drinking water contaminants, once these get into your body, they can bioaccumulate over time. So what is parts per trillion in your environment can become parts per billion in your blood and in your body. So one of the things that came out last year was a modeling effort, sort of a risk assessment tool to look at these and understand if these are transferred into the breast milk of a woman from her blood, what kind of exposure does this create for her infant? And part of our legislative mandate was to go through and be protective of all life stages. So the state of Minnesota developed this modeling tool to basically ask that question. What would your drinking water standard need to be to ensure that if someone lived in a community and used that drinking water across their lifetime, what would allow them this margin of safety so there's no risk to breastfeeding their infants? So by using that tool, that's how we came up with these lower numbers. So it produces these sort of blood serum plots that we are able to go through and look at. I know this is kind of small, but we have a full report that details this. And again, if you have more questions about this, I'd be happy to go over it. But this is one of the reasons why we arrived at these numbers and why we're using them, because we want to make sure that we're not just being protective of an adult, of a child. We want to make sure that we're offering that full protection across all life stages. So again, breast is best. I always want to emphasize, we're doing this to be protective for breastfeeding, but there's very clear evidence that breastfeeding is very beneficial. So again, if you have any questions about this, we do recommend that you contact your physician, you speak with them, because it's a very personal choice. So the questions, what can you do? So if you're a well owner, show of hands, who's a well owner? Okay, we had some sheets in the back, the fun little half sheets. So if you're a well owner, get your well tested, not just for PFAS, but for other contaminants as well, because if you're going to look into treatment options for your well, it's not necessarily one size fits all. There are also naturally occurring contaminants like arsenic around here, there's radon, there's other things that you may want to consider treating for. And we want to make sure that you do that right. Our department is happy to provide advice and help on that. So we have these informational sheets back there about how you can get your well tested. Also, if you're possibly in the area that St. Gobain may be involved in testing your well, there's also a half sheet back there for that contact information. For public users, check with your water supplier. They should have this information. All the water suppliers are beginning testing. They should have testing by, I believe, the end of the year. Clark can correct me if I'm, yes, he's shaking his head, yes. So then if you have health concerns, first off, speak with your physician. And if they're not familiar, have them contact DHHS, have them contact us. We'll make sure that we get them the information they need to work with you. Because again, your health is everything else that goes on in your life as well. So, start with your physician and then we can move out from there. And we're happy to provide help where we can. And then finally, if you have other questions, please contact us. We have sheets back there with frequently asked questions that we get about PFAS. It has contact information for the department. I will be around after this. If you want my contact information, I'm happy to share that. And also, we do have links on our website to getting information about having your well tested. So again, you can use these here. If you want to snap a picture with your phone, you can do that as well. And I believe we're going to be posting these slides onto the DES blog website afterwards. So if you want to check our blog afterwards, we'll have that. So what are our next steps as an agency? So the first is in January, we're going to be submitting a plan to the legislature of how much it would cost, the time that's needed, and what we need to do in order to set surface water standards. So in order to protect fish, wildlife, water for swimming, that's what our next step is. It's a major one. We're also continuing to investigate the occurrence of PFAS throughout the state. We're finding that there's a lot of sites that have different forms of these. Again, it's a very large family of chemicals. We're also constantly evaluating any of the emerging information. So if there's new information that tells us how different ways to look for these chemicals or different health concerns we should be focusing on, we're staying on top of that. And then finally, we're communicating with a lot of our different partners. So we have our federal partners at the EPA, the CDC. We're also working with the surrounding states because, again, it's not just New Hampshire. Everyone else is trying to tackle this. And also working with community partners and our legislatures. We really appreciate all the time that they give to us and the feedback. It really means a lot. And even part of these MCLs are public comment period from all the various groups. So not only our residents, our community stakeholders, municipalities, and also the business and regulated community, and also all these various state partners that contributed. So again, we're staying in contact with all these people because we're trying to help each other figure out what the best steps are. So with that, I will hand it over to Captain Tara Summers from the Agency for Toxic Substances and Disease Registry.
Hello. Now you've heard ATSDR many times, so I guess it's my turn. So again, my name is Tara Summers. I'm with the Agency for Toxic Substances and Disease Registry. Do I need to go closer? Okay, is that better? I know this is really low. It's like meant for very short people, I guess kids. So just to explain the uniform a little bit, because sometimes that is a little confusing for some folks. So I am a commissioned officer in the U.S. Public Health Service. We're one of the 7 uniformed services. We fall under the Department of Health and Human Services. And have you ever seen the Surgeon General on television? Many remember Surgeon General Koop. He was one of the most famous. We report to the Surgeon General. So by background, we are all public health professionals, engineers, doctors, nurses, some like toxicologists, and we work within federal agencies to provide public health support. So I work for ATSDR. This is my 18th year. I'm just finishing my 18th year at ATSDR. I'm a nurse by background, and I do occupational and mostly environmental health. I don't have a lot of slides, so we'll hold on that for a moment. So ATSDR, you've heard our name now several times. We are a federal public health agency, and we're a sister agency to the Center for Disease Control and Prevention, which is a name more people have heard. Our job specifically is to look at chemicals in the environment and determine if they cause harm to human health. So we have a very sort of like narrow track that we work in. You've heard of CDC. They work on a lot of like infectious disease. We work on environmental health. So that's how we fit into sort of the federal picture. We provide support to our states, and we also write documents called health consultations or public health assessments. And what we do is we collect data that's collected in the environment, so in the water, soil, air, depending on what the contaminant is. And then we use a process that we have at ATSDR where we determine if the level of those contaminants in the environment are likely to cause harm to human health. on a short-term basis or a long-term basis. And so that's really the bulk of the work that we do. And for those health consultations, here in this area of Merrimack, New Hampshire, we are working on 2 health consultations. We were asked to do this by the state of New Hampshire. So we're working on 2. One is on private drinking water wells in the towns of, I want to make sure I have everybody, Merrimack, Manchester, Londonderry, Litchfield, and Bedford. So we're looking at the private well data that we were given by the state for those communities. And we're also going to write a health consultation that focuses on the public drinking water systems for Merrimack Village and the Pennachuck Waterworks distribution system. So there'll be 2 documents coming out. These documents, again, what we do is we take the data that's given to us by the state. We'll evaluate that data using our, we have minimal risk levels, MRLs, as opposed to MCLs, which the state sets. And ours is a dose. So it's a little different than what a state regulatory agency does. A state regulatory agency can set levels in drinking water that they consider safe for you and the population of New Hampshire. What we do is we do toxicological profiles, and we determine a dose that we think is safe for someone to have over the course of a very long time, and then we compare the data that we're given and determine if that data shows us that the amount you would get in you as a dose is higher than something that might cause a health concern. So that's how we do our work. I know that's a lot going on. I'm also going to talk about, and I think this is on the slide. So those 2 documents, the health consultations, they're not studies. When we use the term study, we use it in a very specific way, where a study is looking at, you know, a health effect that comes from a specific evaluation of people in the community. Our health consultations, again, we're starting with the environmental data and determining if we think it may cause a health effect based on the levels that we found. So beyond our health consultations, we do have some other work going on at ATSDR, and this is across the United States. Some of it's happening here in New Hampshire, some's happening in New England, and some is happening across the US. So some of the things we have happening, we have these exposure assessments that Dr. Chan referenced. And what we're doing there is at 8 communities across the country. One of the sites is in Massachusetts, that's one in New England, in Westfield. We are we just finished the data collection, so the data collection part's been done. We reached out to residents to have them participate with us, and we had people come and give blood and urine samples, and then we'll evaluate that to see how much PFAS is in their blood serum, and we can then determine, like, if that population of people, like that community that had the drinking water exposure, has a higher level of exposure than the rest of the US population. So we're doing those exposure assessments at 8 sites across the country. And that is gonna help us figure out, when people have drinking water contamination, how does that affect how much PFAS they have in their bodies? So that's the exposure assessments. We have a study that's happening at the Pease Trade Port, and this is a study that we just launched less than a month ago about. We had our first public meeting to start enrolling people in the Pease Trade Port study, and that is to help us determine, for people who worked or were children at the childcare on the trade port between 2004 and 2014, if they were exposed to the contaminated drinking water. We're now looking to them, and we are collecting that study. That's the type of study where we collect biomonitoring data about those individuals who are enrolled in the study. So we're going to look at the amount of PFAS they have in them and look at other biomarkers such as cholesterol levels. We're looking at immune function. And so that's going to help us try to start making those connections between the amount of PFAS people have in their bodies and maybe some of the health effects we'd see based on that. And those 2 activities, the exposure assessment and the PFAS study, they're also fit into the Multisite Study. And the Multisite Study is following the same protocol as the Pease study, but it's being, again, conducted across the country at 8 different locations, well, 7 including Pease, so 7 additional locations. And they're using, again, the same process they're using at the PEAS study. And what that helps us do is so now we can enroll like a bigger population of people. So across the country at the multi-site studies, we'll have up to 6,000 people enrolled, 2,000 children, and that helps us make better connections between the amount of PFAS we're seeing in people and any potential health effects we might find through the testing they're doing. So those are the big projects we have going on right now. I know that's a lot, and I think I have one more. This just talks about the study process, and this one says PEAS study process, but it's similar for the others across the country, the multi-site study. So first, there's the community engagement part, and that's where ATSDR and our partners who are conducting the studies with us and some of the other sites are reaching out and getting community members involved and wanting to participate. We then have the recruitment effort, and that's what's happening right now at PEAS Tradeport. The other multi-site study sites are not at that process yet. They're a little bit further behind. The PEAS one is the first one to launch out the door. But again, because all the information will be collected the same across sites, we'll then be able to aggregate or put together all that information, and it'll help make for stronger conclusions. So the data collection is when people come and actually, participate at the study location and give blood samples. Then the analysis, that's the part where the blood samples are sent to the lab and the lab performs their functions. Then individuals will get back their results. So each individual who participates will get a list of all the things we found for their blood serum samples. And then there'd be like a community event where we share the results. And again, we don't share individual private data. We're talking about sharing kind of like the state of New Hampshire did when they gave their report. It was about the community, not about an individual. And then the study results ultimately will be published. So this process here, it only looks like 6 or 7 circles on a slide, but it's going to take a fairly long time. If any of you have ever been involved in a study like this, it will take a couple years. The recruitment process is happening now. It'll probably go on for at least another year, 18 months, until they reach the number of participants they need. And then the subsequent studies, as they get off the ground, will take probably about as long. And then it takes some time for all the data analysis to happen. So this is a process that, hopefully maybe, I would guess 2 years from now, maybe we can come back and update you at least about the conclusions of the PEAS study. And then moving forward, we can also update about the multi-site study. And I know Dr. Chan also mentioned that Merrimack area, there was a proposal put in to be one of the sites selected for the multi-site national study. And although this area wasn't part of that process, the results we find in this study, and especially the national study, the multi-site national study, those results do apply to other communities across the country. So hopefully with this information, we will be able to answer more questions, not only at those sites, but at sites across the country. So with that, so here's my contact information. I'm in our Boston office. I'm the regional director for the Boston ATSDR office. We cover all the New England states. So you can call me, you can email me. We try to get back to everybody that contacts us. We have a small regional office, so sometimes, if we're not in the office that day, it might take us a little bit to get back to you, but we really do try to get back to everybody who contacts us. And this is our website where you can find additional information about PFAS activities that are happening at ATSDR across the country and all the sites. So I tried to keep it short so we could have questions. I'm sure you have questions. You want to get over there? Hopefully. Okay.
Did everybody get the information they needed? You all set? Okay. Cool. Sorry. Yeah, he's putting it. Oh, it's great.
I feel like we're really far back now.
Wow.
I know.
We're taking care of that.
Oh, thank you. Thank you, Jay.
Yep. There you go. All right, ladies and gentlemen, we do have a mic here at the podium. If you've got questions that you'd like to ask, they're right here. Feel free. And please identify yourself and let us know what town you're from.
Hi, I'm James Rossi from Merrimack. And two quick questions. One might, as far as I know, is a nil answer. You said, what can we do? As an individual, what can we do to maybe, other than not consuming more, reduce the amount of PFOAs or PFASs in our system? Can anything be done?
That's a great question. Yes, repeating the question. So your question was, what can be done to reduce the PFAS, the chemicals in your system? You know, I think the first priority is always to stop the exposure, right? I mean, or minimize the exposure as much as possible. I mean, as I mentioned, it's very difficult to have no exposure to any of these chemicals because they're in, products all around us. There's not much that is able to be done to actively remove them from your body. Some of these chemicals may leave your body very quickly. Some of them can have half-lives on the order of several years. But once exposure is stopped, what's been found is that the body burden decreases slowly over time. There's not currently any approved medical therapies or ways to remove these chemicals faster from your system, unfortunately.
Okay, and the second, that's exactly what I expected, by the way.
Yeah.
The second question is, it seems as though we are focusing on 4 particular compounds out of a family of thousands, many, many thousands. We only have a limit on 4 now. And I'm wondering why we can't put a reasonable limit, in my mind would be an average of the 4 that we know, on the rest of that family of compounds so that we can actually take action to clean up everybody's spewing of chemicals in the state. Why are we limiting it to what we have problems with instead of what we don't know what we have problems with?
Can you hear me? Yes?
Yes.
Everyone can hear me in the back? Okay. So those 4 compounds were selected because we had occurrence data on those in the state, and also because those were the compounds that we had confident information about their toxicity. The problem with trying to apply that same approach to all of the other 4,000 is 2 issues. One, it is a very large family, and there are several what we call CAS numbers, so they're chemical, it's like a social security number for chemicals. They each have their own individual number. There's over 4,000, closer to 5,000 of those identified, but not necessarily all of those are in commerce or possibly being released into the environment. Some of those may have just been synthesized in a lab and aren't necessarily being used. So
Wouldn't it be more prudent to encompass them in the restrictions so that if we do find them in the pollution or in the public spectrum, that we could actually do something about it immediately?
Well, part of that is the issue that we don't have detection technology for all of the chemicals. And also, some of these, they seem to leave the body faster, which affects their toxicity. So that's where some of them may have similar biological effects in the body, but if they leave the body much quicker, they're less likely to cause an impact at similar levels as these. So that's one of the issues that we've run into with trying to address them as a class. And that's something that the EPA is trying to work on right now, is coming up with a robust approach to addressing these as a class of compounds. But at this time, it's something that we don't have.
It seems like we're kind of always behind the 8 ball with the exposure. That's why I'm asking.
Yeah, it's a challenge, and it's kind of the question of, it would have been better to have the toxicity data on these chemicals before they entered the market, but.
Dr. Chen?
And to your last point, your last point is it highlights the larger issue of regulation of chemicals in this country, which is an ongoing issue, an ongoing point of discussion. But your second question there is part of an ongoing discussion in the toxicologic, scientific, public health community about how to look at these chemicals as a whole. And there isn't yet consensus on how to do that, but it is something that's actively being looked at by state agencies and the EPA. But it's not, just because one chemical is thought to be toxic doesn't mean that they all necessarily are, but that there's a lot of data that we're lacking on many of these other chemicals.
Thank you. Yes, sir.
George Heavner, Merrimack. You talked about public water, you talked about wells. Do you have anything to say about bottled water?
So we have, I'm looking at some individuals who oversee regulation of bottled water.
Okay, so we did have, through DES, tested bottled water for PFAS, and there is a listing of bottled water that has been tested. We have some proposed rule changes that we're working on right now to include PFAS testing in all bottled water as part of our regulatory authority. Is that so? As Dr. Chan was about to say, we do have our food protection manager here in case there are any questions that I can't answer, that we can't answer.
I will say that most of the bottled water that has been tested has been found to have non-detectable, if not very, very low levels.
Okay. You also mentioned that the domestic production of several of these compounds has been stopped, but are they still imported?
So, correct me if I'm wrong, Tara or John, but so it's again, 2 of them have stopped use in the United States, to my understanding, PFOA and PFOS, just those 2. But these are still used in some countries overseas, and I believe that also means that products using them could still be imported. Is that correct? Is that your understanding?
That's my understanding. I'm not an expert at the import process, but that's my understanding. There's also some, they were often used in firefighting foam. The AFFF foam is a way that many sites around the country seem to have had their drinking water systems impacted by these chemicals. And my understanding too, it's being phased out, or new foams are in production, but there may still be some legacy that's out there.
I guess
So-
the question is, since we've stopped production on a couple of these, what's to prevent manufacturers from simply buying in bulk overseas?
That's a different State Department.
Sorry.
I'll accept the answer.
We can't answer.
Thank you, sir. Go ahead.
Catherine Hodge, Merrimack. Dr. Chan, you said that in order for us to stop having the chemicals in our bodies, that we have to stop our exposure. We cannot do that. We have an active polluter in town. Taryn, all the studies that are being done, they are all AFFF studies. There is not one industrial contaminator in that set of the 6 or 7 studies that are being done. And why are you testing someplace, meaning Pease, which has had no contamination since 2014, when we here still have contamination to this day and will continue to have contamination until St. Gobain gets stopped?
So the question is about the study sites and their link to the AFFF foam that was used at Department of Defense sites.
Every single study that's being done out of the 6 or 7 is all DOD sites. They're
So-
all contaminated by AFFF. There is not one industrial site in any of the ATSDR studies.
Okay, so I think I understand the question. And so for the exposure assessments, the ones that are being done like in Westfield and
Correct.
8 sites, right? For the exposure assessments, the way the funding came to ATSDR, those had to be linked to Department of Defense sites. So the exposure assessments, you're right, are linked to Department of Defense sites. When the announcement was open for communities to participate with the study, the multi-site national study, that my understanding, that restriction was for DOD-related sites, was not part of the multi-site national study application process. and selection. So like Hoosick, New York, I believe is a non-DOD industrial player, like St. Gobain. And so they are in that multi-site study in New York, I believe. They might be one of those. I can go back and check though.
Okay, that'd be great.
Because I don't know all of them. You know, I try to keep up as much as I can, but it's hard with so many across the country.
It just seems pretty convenient that A, the industrial sites were left out, and B, we did put in a really heavy application and we were denied. And it just seems really strange that we're still being denied. And we've only had 217 blood tests, and all of our levels were at least 4 to 5 times higher than the national level. So why are you guys scared to test us?
Thank you.
Hi, I'm Rosemary Wrong. I'm from Merrimack. I'm also a state representative for Merrimack. I have a question and a comment. Dr. Chan, you had a slide that showed the decreasing exposure to the for PFAS. But are there other studies being done on the next generation of PFAS chemicals?
Again, this is the limits of my knowledge in terms of what's happening nationally is a little bit limited, but there are, I know, other sites that are investigating potential contamination from other of the newer generation of PFAS chemicals. I'm thinking of like North Carolina and Gen X. But, you know, I think that there is awareness out there in terms of newer chemicals that are replacing the old PFAS chemicals. But as Dr. Olli mentioned, sometimes our ability to even test for or detect some of these can be limited.
Okay. My comment is I am feeling very frustrated, concerned, and maybe a tad bit angry that the communication we've been having with clinicians doesn't seem to be working. It's vitally important that we reach pregnant women and women that are nursing to warn them. And I think just tossing our hands up and saying, well, our communications isn't working so far, isn't acceptable. I want to quote from the Minnesota study, which was a driver for the MCLs that were set by the state. And this is in the first paragraph. Even short exposures during infancy have dramatic impacts on serum levels for many years. In addition, developmental effects are the critical effects anchoring recent risk assessments. I think it is vitally important for the state to address this lack of communication with a lot more urgency. If we can't get clinicians to advise their patients on water consumption, then we need to go directly to the public. But there is no reason why any woman who is considering becoming pregnant or is considering breastfeeding should be consuming public water that exceeds the MCLs. So I would urge both departments to prioritize communication to warn these women about taking proactive measures to ensure that their themselves and especially their babies don't have these levels of PFAS that were studied in this study. Thank you.
Good evening. First of all, I want to say thank you for coming here and offering Merrimack this opportunity. You already know I'm Nancy Murphy. I'm a Merrimack resident and one of the state reps. A couple of things. I think you are all aware that Merrimack is very concerned about what we see as potential health impacts that are being experienced. What we have here is a lot of anecdotal information. Given the limited number of blood testing and our failure to have access to a health study, we don't really have the tools with which to show harm. And that's one of the challenges, that how do we prove there is harm when we don't have the tools to do so? I'm asking tonight, I know in the past we've had conversations about the lack of information that our health providers in local communities seem to have about PFAS. And I know that you have reached out and I know you've sent emails, but given my experience with a number of providers across the state around this subject, especially those with seeing patients that might have those impacts, endocrinologists and such, that they really don't have a sense of the issue. I'm not saying that they weren't informed, but given maybe the number of emails they get, that it becomes a low priority. I'm asking for your support. I've submitted an LSR, which will be in concert with the New Hampshire Medical Society. I'm asking for education of physicians across the state that it really not be a choice anymore. I think many providers went to school prior to this being a known issue, so it wasn't part of medical school training, and there's a lot of catching up to do, whether it's through continuing medical education or conferences or whatever. I will be meeting with them to discuss it, but I would hope that you would support this in the best interest of communities across the state. In addition to that, I have two other bills that I think will hopefully, again with your support, might help out down the road, sort of incrementally looking at health impacts. One's an LSR about bottled water. Another is in concert with, there are two commissions that I sit on. One is on environmentally triggered chronic disease, and another one is more specific to our local communities in southern New Hampshire and the impacts from St. Gobain, and just to determine what the true extent of the contamination is, as well as the potential health impacts on community members. One of the other bills is related in terms of AFFF firefighting foam, which we know is another source of PFAS exposure for community members, and looking at trying to figure out where are we seeing health impacts. Not having the tools with which to do so, one of these bills will look at where AFFF is stored, where it's used, with the eventual hope that we can overlay exposure to these things and with the potential health impacts that we'll be seeing in the long term. So I think there's a number of things that we're trying to do, but again, things are just incremental, and it seems like stopping our exposure, of course, would be number one. And since that doesn't seem to be happening anytime soon, the more informed our community is about how to protect themselves, I think it's certainly important. And I thank you for coming tonight to share that.
Thank you, Nancy.
Thank you. Sure.
Well, and thank you for your work as well. And we'll have to take a look at those LSRs. But I want to acknowledge again that reaching clinicians and educating clinicians has been a challenge, not only on this issue, but multiple other issues as well. And so we're constantly looking at ways to improve how we communicate and reach out to clinicians. As I mentioned, we've sent out a number of different Health Alert Network messages to clinicians. And you're right that clinicians get a lot of messages in their email inbox, and that kind of information can be disregarded. It hasn't just been Health Alert Network messages that we've sent out, or it hasn't just been emails. The ATSDR has developed webinar continuing medical education resources that we've put out there to clinicians. We've put on in the past webinars ourselves for clinicians. We've had a couple of sessions with the New Hampshire Medical Society working with clinicians, trying to educate them. We've made call-in resources available for clinicians at point of care. So a lot of times healthcare providers won't pay attention to an issue unless they're seeing a patient right in front of them that's presenting them with their concerns around chemical exposure. And so we've tried to make resources available right at the point of care. So we've done a lot of, attempted to do a lot of outreach to healthcare providers, but you're right that there's certainly more that could be done, and that's something we're constantly trying to work on and improve our communication to healthcare providers.
I also want to mention that on the table in the back is a letter that you can bring to your providers if you have concerns, to give them some education around PFAS as well.
Thank you.
So I guess this is just kind of a really basic question.
Can we have a name and town,
I'm
please?
so sorry.
That's all right.
Yes, Nancy Davis. I live in Merrimack, and we're on public water. So actually, I have two questions. The first one is just, if you lived in Merrimack and you're on public water, and I guess you could repeat the same for the other sources that are affected, would you drink the water, or would you buy bottled water? And then the second question is, Is anything being done for people in poverty who can't maybe afford to get bottled water?
So,
Dr. Ali, you want to address that?
yeah, so as far as dealing with the economic issue, I think actually Clark would have more answers as far as what the department is doing with municipalities and also with those in the impact area. So I don't know if you want to sort of address that economic disparity.
Nope.
So since I'm new on camera, I'm Clark Fries, I'm the Assistant Commissioner at DES. My back is killing me already. Can I just pick this up? Yeah. Thanks. Those chairs are not comfortable. I will not push the button. We were given a small amount of implementation funds with the new MCLs, and we are trying to focus that on especially small water communities because the financial impact per person is huge. That also does help those who are of lesser means because, again, the multiplier through the number of bodies in a water system can become absolutely overwhelming. We are trying to set up a fund. There is a bill being put in. It's an LSR, so I'm not supposed to share because I'm not a legislator. It is, I just read the latest draft today. We were in a conference to go over it, and it does focus on disadvantaged communities ought to be given grants, at least partial grants, in addition to low interest loans. So there is a focus on that. In addition, although it's not for PFAS, arsenic is also a very large problem throughout the state, and we are trying to work out a pitcher program for disadvantaged pregnant women. So we do have a number of programs. Also, all of our loan programs do take into account the means of the community. So we do try to focus on that to the degree we can within the funds we have.
And if I can also mention that, right, I mean, marginalized, disadvantaged communities, impoverished communities, it's not just an issue of contamination. You know, there's issues around, you know, access to, you know, food and food insecurity and access to housing and healthcare. So I think that the points you raise are a good one. We don't have necessarily a clear-cut answer to those, but it's part of the larger issue of, you know, health equity and you know, addressing the issue that poverty brings to one's health and the impact it has on their health.
Thank you.
And to the first question, because I was not dodging that, I just wanted to make sure Clark answered while that was on my mind. It would be no, because the point of the MCLs is to be protective for the entire population. And it's... Oh, sorry, the question or...
Repeat the question, please.
No, so if the water was above the MCL and I was getting it from a public supplier, so I live up in Manchester, and if the Manchester water was above the MCL, I wouldn't drink the water.
Thank you. Wendy?
Oh, no, he said no. He said he would not.
You did answer it.
Right, if it's above the MCL, then no.
It is, yes.
It is.
It is. Yeah, I guess that's the piece that was missing, yeah.
I just want to answer that as well. So I don't live in southern New Hampshire, but I have to admit that I have a private well, and I only recently got my well tested, and it's shame on me, right? So shame, but there's a lot of contamination in my well. So of a variety of different toxins, and so I have to be thinking about how to ensure that myself and my family are well. So I think it's really important that you get your well tested and that you try to figure out how to reduce your what's it called?
Thank you.
Exposure. Sorry.
Go ahead, Wendy.
Thank you. I'm Wendy Thomas. I'm from Merrimack. I'm also a state rep. Speaking of reducing your exposure, nobody's talking about food. And in Merrimack in particular, because we're contaminated on a daily basis with air particulates, it's getting into the soil, and PFAS is in our produce, it's in our animals that are raised for meat, it's in our milk from the animals. It's in our chickens' eggs. They've done a lot of work on this in Italy. Is the state of New Hampshire looking into food contamination? From PFAS specifically?
Yeah, so we did, I'm trying to remember, Clark and Colleen, was it a year and Ben, a year and a half ago, 2 years ago? We tested milk, and we found non-detect in all samples. So just for you to know that, but I can't speak to the other products.
And some of this has involved discussions with the Department of Agriculture, and I think you're bringing up issues that span multiple state departments: Department of Environmental Services, Department of Health, Department of Agriculture, Department of Fish and Game. Especially, you're talking about fish samples, and these are ongoing discussions that I know we've had in the past, and continue to be questions that are raised.
I just want to alert, we've got about 5 more minutes to deal with questions. So,
Hi.
Janine, I think the gentleman beside you, no, you're all set? Okay, go ahead.
I'm Janine Nodder. I'm the Science, Tech, and Energy Committee, so I've met you before. I remember talking to you, Dr. Chan. Can you just clarify your answer? We didn't hear you very well in the back. You said you wouldn't drink the water if it was above the MCL level, but did you mean 12 parts per trillion or the previous level of 70 parts per trillion?
12, because that's the MCL.
Okay,
70 is the EPA's lifetime health advisory, and that's what was temporarily adopted, but our MCL for New Hampshire is 12 parts per trillion.
But would you cook with it? Not boiling, like
No,
noodles?
because
Or
if you-
what about steaming vegetables?
So no, you wouldn't want to do that, because if you try to boil it, you will actually concentrate it and then give yourself a higher dose. So that's why for a lot of contaminants, for chemical contaminants, you typically don't try to boil them out unless they can become gases. PFAS won't do that. So you wouldn't use that water for cooking.
And I had one other question about bottled water, because I hear a lot of different things. If bottled water is cooking in a hot truck or your hot car, or if it's put in the freezer, does the chemicals in the plastic leach into the water? And is that also not healthy?
Can you answer? I don't have the expertise for that.
Yeah, so I think that we've tested bottled water off the shelf.
Yeah,
That's been
saw
sitting.
that here.
Yeah, it looks like
Yep.
you have the results there that have been sitting in bottled water, and most of those were very, very low levels or non-detectable levels. Again, I don't have the results right in front of me, but I think your question is more about other chemicals potentially leaching into the water from plastic, and that's not something that I'm not sure what chemicals exactly are all in plastic. You have plasticizers, but I don't know the information behind leaching of other plastics and chemicals into drinking water and how frequently or at what rate that happens.
Thank you.
Barbara?
Hi, good to see you. I'm Barbara Healy. I'm from Merrimack, and I'm one of the town councilors. So you're getting the whole legislative realm here. A couple of comments and then a couple of questions. First of all, folks who are here, you have those sheets in the back that are guidance for the physicians. They're also available online. If you have concerns, copy them, get them from the back, take them to your doctors. Be proactive. You all were proactive to come here tonight, so let's be proactive in helping to educate our doctors as well.
Barbara, we're short on time, so
I've
get
got
to your points.
My real question that I'm
Yep.
wondering is, here in 2005, St. Gobain was testing in their dip pans. They were testing at 2,000 ppm of the APFO. After the reformulation, then they were down something like 95% down to 75 ppm. And those are still quite high, especially in the early days of the 2005. They were astronomical. Is the research that's being done looking not only to see the effect of PFAS in your bloodstream, but for those that were actually exposed to very high levels of PFAS, is that taking place as well? Because that may have some difference in the results. Thank you.
So the studies that are out there that are looking at exposure, The primary route of exposure, as I said earlier, is by oral ingestion. I think you alluded to smokestacks, and it is possible for people to also be exposed by inhaling fumes, for example, that contain PFAS compounds. But by and large, the primary route of exposure is going to be oral ingestion, and that includes, stuff that is emitted from smokestacks can remain suspended in the air before it falls down to the ground, and then gets, leaches into groundwater, and then people consume it in the water. When we're talking about exposure assessments, we're talking about assessing exposure through all routes, again, primarily oral ingestion. If someone inhaled some fumes with PFAS, it wouldn't take that into account as well. But the studies are varied. There are animal studies, as Dr. Olli alluded to. Some of the early studies have looked at occupational exposure, people with very, very high levels of exposure. If you remember the graph I threw up there with the horizontal bars, that very large bar was occupational exposures to PFAS, all the way down to the community level where there have been lower levels. And so the studies that are out there are looking at a range of different exposures, all the way from very, very high levels in occupational workers, all the way to the community level, even laboratory animals. And again, the primary route of exposure is going to be oral ingestion.
Quick question, we're running out of time here.
Michael Peterson, Nashua. I have, as a non-scientific lay person, I have a couple observations and concerns. One is, like when I drive on Route 3A in Litchfield, they have all those farms with people buying food, and those farms are right downwind where the PFOA contaminated the soil and the wells, and yet they're pumping that water onto the plants all summer long, and the people are buying it and bringing it home and eating it. And then I think every day St. Gobain is still contaminating, still releasing poison, and I don't see any intervention by our state government or federal government to stop them. Can't they just put a hold on it? I mean, that's my concerns and my questions as a citizen. Thank you.
Thank you. Lorraine, if you want to do one quick one. I know it's hard. Okay.
Sir, those chairs are crippling. I don't know how everybody's. So as far as the testing in Litchfield, at the beginning of the investigation, we did soil testing at all sensitive sites, so playgrounds, daycare centers, and schools. And we also included agricultural fields, especially agricultural fields that produce product for human consumption. All of the soils that were tested were actually relatively low. We have a contact standard, and they were orders of magnitude below that. So we're actually believing that because the soils here are very sandy, that we do, and unfortunately it tends to then leach through quickly. That's why it delivers to the groundwater as well as it does, unfortunately. So that was the first half of your question. Second half was about continued exposure. The primary exposure out of the plant was through the sewer system, getting out into the environment through the sewer system of Merrimack. They have a treatment system on that now, so that is no longer exposing. I don't know if Sarita's here tonight. Anyway, the person who runs your system is Sarita. She's tested, and she said it's actually working really well. We did see exposures to the groundwater through leaking pipes and direct ground exposure. We are trying to address that through the site investigation, make sure we know where it is, and there may have to be an active remediation to get that back out. From the air standpoint, we have done air testing. They are now down to the point where PFOA, they're exposing about 1 pound a year. They used to put a couple tons a year out. We are demanding that they put air treatment on. We had a hearing for an air permit. They have proposed what is considered the latest and greatest technology for the air treatment. They have a year once the permit is put out to put that treatment on and get it running. That actually is a brand new state law. One of your local legislators, Dick Hinch, was key in getting that passed. Until then, we could not do anything about their air emissions, basically. So this is a brand new capability. We are pushing it. The day we got the authority, they had a letter demanding it. They have met their deadlines, not by much, but they've made their deadlines. We have to get the final permit out, and then they have a year to get that turned on. At that point, we believe with the technology they proposed, it will be way, way down. I no longer believe in the number 0. The number 0 doesn't exist. but it will be way down. Right now they're down to, like I said, about a pound a year of PFOA, and we're hoping that we'll get to at least 90% reduction from that. Sure.
Lorraine, real quick, because we promised we'd get them out by 7.
Hi, Lorraine Allen, Merrimack.
That's for additional one-on-ones.
Where to begin? So we have 190 PFAS emitting. I don't know if DHHS knows that. DES is doing a great job in testing. They have help from the EPA ORD. So 190 PFAS out of the 4,700 that we know about. So we know those are here. And we're doing a great job with testing. We did a great job with the MCLs. We're leading the nation in the mapping. We're doing some really good things here. But what we feel as a community is we're left with what is the support we need. The studies, the national studies, is very expensive. You know, we're not going to get something like that on our own. We can't fund that as a state. I know that. So I think we really need to look at resources and where we need to hone in. A lot of the information presented here was good information, but it was general. It was the background, and you know this, it's about the chemical class and the stuff. So what I think we need is we have local legislators here, we have state officials here, we have town officials here, and we have representatives from our federal delegation. So I think I'd like everybody to maybe put their heads together, you know, when you all go home and talk as officials, what are we going to do to earmark what we specifically need here? It isn't just answers, it isn't just physician support. We do know our exposure. We know our water exposure, we relatively know our air exposure. The science is focusing on, you know, the legacy compounds. We are an active contamination site. You know, you hear this phrase all the time. So the support that we need here is a little different. And I would like to propose that maybe we look at Merrimack as Merrimack could be an amazing model for the rest of the country in terms of if we could figure out how to respond, how to truly respond to a community that we know has exposure, past and current exposure. What are the needs? What's the needs assessment of this community? How do we do a little more than a health consultation? You know, government moves slow. The health consultation was requested, right, Tara, in August of 2016. We've spoken many times in the last few years. It's the end of 2019. If we wait for the science to come in till we know definitively where the harm is, we have amazing NIH and NIH studies out there that really do talk about pancreatic functioning, talk about neurobehavioral and neurocognitive things. There are many, many things out there. We need to take all these things, pull it all together, and apply it to a community that we know has impact going on right now, so we can be armed, we can be preventative. We are having to educate our own physicians. Not everybody can do that. So the handouts here are great, and I know the ATSDR handout talks about air, soil, water, and background exposure, all of it. That's really good to see, because a while back it didn't have all of that acknowledged. The ATR, is it the minimum or maximum, the MRLs as opposed to MCLs, are lower in some cases than our MCLs. So for children, the draft, and I know it's held up for a long, long time, but the draft, I believe, was 7 and 11 for PFOA and PFOS, and then they did it for short-term exposure instead of long-term exposure, and it got a little wonky there. So we're exposed. We know we're exposed, we know there's harm, and we know we need some help. The question is, what is that help? Where is the education, and where is the way to arm people to really protect themselves? You know, the whole community, if we reduce air emissions, that's great, but these are forever chemicals. You know, they're not going away, and we're here, and a lot of people are very, very frustrated over what we don't have for guidance and supports and a little better education of people, because that's all we can do at this point is educate people.
Thank you. Ladies and gentlemen, the 4 consultants up here have agreed to stay for a little bit and they'll be out here on the floor, and they will do one-on-one questions with you or address any further concerns. So they will be here.
I also want to mention that Colleen Smith and Michelle Roberge, if you could stand up, who is from our food protection program, and they regulate the bottled water. So, so you can chat with them if you have questions relative to bottled water.
They're going to hang out as well.
Thank you.
Thank you.